Greetings and welcome to today's webinar discussion titled PSMA Imaging Biomarkers in the Management of Patients with Prostate Cancer, hosted by Amplity Health and sponsored by Lantheus. Today we will be joined by our esteemed panel. Dr. Hong Song is a board-certified radiologist and nuclear medicine physician at Department of Radiology and Nuclear Medicine at Stanford. His research is focused on nuclear medicine, imaging, and targeted radionuclide therapy, including PSMA. Dr. Andre Grafita is a nuclear medicine physician in the Department of Radiology at Johns Hopkins Medicine and is leading the prostate cancer theranostics program. His research is focused on biomarker development and validation, including the RECIP criteria for prostate cancer. Dr. Michael Morris is a board-certified medical oncologist and is the prostate cancer section head at Memorial Sloan Kettering Cancer Center. He is well known for his work in the development of the targeted radio imaging and theranostic agents, including his leading role in the phase 3 clinical trials, Osprey and Condor trials, which led to the approval of Clarify and Vision trial for the approval of Pluvicto. Dr. Asim Anand is the Vice President and the Head of Digital Biomarker Solutions at Lantheus. His work is focused on the adoption of deep learning-enabled biomarkers in clinical trials and in clinical practice. For today's webinar, he will be the moderator. Throughout today's webinar, please feel free to submit your questions through the Q&A option on the bottom of your Zoom screen. At the end of the program, the panel will address the questions received during the Q&A session. If we happen to run out of time and do not get to your question, someone from Lantheus will reach out post-webinar. It is now my pleasure to introduce Asim Anand, Vice President and Head of Digital Biomarker Solutions at Lantheus, to start the session.
Thank you, Jimmy, and thank you all for joining our webinar. Thank you, our esteemed panel. We are really looking forward to an exciting discussion between ourselves and also just focus on the exciting world of PSMA. Before we begin, next slide, we would like to go over some due diligence on disclaimers. So just bear with me. Today, we will be discussing PSMA imaging biomarkers, quantitative biomarkers, and we do have an analytically validated and also FDA-cleared platform that generates quantitative assessments for PSMA. The platform is called aPROMISE and is also known as Clarify AI. The platform is a deep learning application, software as a medical device. It was inspired by the PROMISE criteria published in 2018 and subsequently adopted also as a consensus by the ENM. The application was developed by Exini Diagnostics, which is a Swedish entity, but a wholly owned subsidiary of Lantheus Medical Imaging. Next slide. The objective of the panel discussion today is to really highlight the PSMA imaging biomarkers and how these biomarkers can be validated in the context of PSMA radioligand therapy. So the discussions would really look at the quantitative PSMA imaging biomarkers that are playing a very important role in treatment selections and also monitoring. However, we also agree that the enhanced clinical utility of PSMA PET goes just beyond saying yes or no, or presence or absence of the disease. It is why this is consistent and quantitative biomarkers are really important. So we can go beyond the realm of diagnosis and begin to qualify PSMA PET as an imaging biomarker. So the discussions will really focus on what are the imaging biomarkers, how we are qualifying and validating them, and in what clinical context. In the next slide, I just wanted to brief the agenda. So discussion will start by presentation by Dr. Song, who would be focusing on what are these quantitative biomarkers. Subsequently, Dr. Grafita will be addressing the quantitative biomarkers in response assessment, the RECIP criteria that he has developed and has been validating. And finally, Dr. Morris will be focusing in discussion, how do we take these biomarkers from clinical trials into clinical setting, and how do we qualify them and validate them in their context of use. So next slide, without further delay, I would love to hand off the baton to Dr. Song. And Dr. Song, please take us through your presentation.
Yeah, thank you, Asim. Good morning or good afternoon, everyone, whenever you are. And hope everybody had a good Valentine's Day. I'm going to talk about quantitative PSMA imaging biomarkers in prostate cancer. Next slide, please. Yeah, so PSMA PET, including purified PET, has been approved by FDA and in clinical practice for almost 3 years now. And it's being adopted by many guidelines, including NCCN, SNMI, ENM guidelines, and the indication that we see on the slides almost include every stage of prostate cancer at initial staging, at biochemical recurrence, at when patient was is diagnosed with castration-resistant prostate cancer. Now more sort of with the improvement of lutetium PSMA, PSMA PET has been adopted to evaluate eligibility of patient for lutetium PSMA treatment, and also for evaluating treatment response for lutetium PSMA. So almost all stages of prostate cancer. And it has been pretty well established by now that PSMA PET is more sensitive compared to conventional imaging to evaluate or assessment disease status. But we know there are probably a lot more information we can extract from this PSMA PET, more than we currently use in clinical practice, especially quantitative information that can be extracted, that can help us or guide us to make clinical decisions. So the question really is, what or which quantitative parameters or biomarkers are clinically relevant at different stages of prostate cancer and potentially can serve as prognostic or even predictive biomarkers for us to help us guide clinical management. Next slide, please. So by now, many excellent works have been done in this area. We will hear a lot of that from Dr. Kafida, Dr. Morris. I want to just touch the sort of some of the basic sort of major studies we have seen so far, especially in the realm of evaluating eligibility for lutetium PSMA and treatment response to lutetium PSMA. Out of that, it turned out SUV mean is a critical quantitative parameters on PSMA PET for evaluating eligibility of lutetium PSMA treatment. So this is initially from a therapy trial, phase 2 therapy trial from Australia. They found that a higher PSMA, a high SUV mean over 10 is correlate or predictive of higher likelihood of a favorable response to lutetium PSMA in that patient population. Dr. Morris will have more in-depth discussion of that study. And Dr. Kaur, in a post ad hoc analysis of the VISION trial data, also demonstrated that a higher SUV mean over 10 correlate with better overall response. You can see some of the data here. If they divide SUV mean into quartiles, SUV mean over 10, the blue line is a top quartile. You can see it separate out from the remaining 3 quartiles very, very well. And the top quartile with a median survival of 21 months compared to the lower quartile below with SUV mean below 10, with the overall survival, median overall survival about 14 months. That's a big difference. So another quantitative parameter on PSMA PET is total tumor volume. So Dr. Gafida will did a lot of work in that area. We'll talk about that in depth. So this is essentially used to evaluate treatment response to lutetium PSMA in terms of change in total tumor volume on PSMA PET. Now, one thing I have to emphasize here is that the SUV mean we talked about is not SUV mean of individual lesion. Rather, it is SUV mean of total tumor volume for this patient, like every single lesion add up. So this is a very important concept, that it's not a SUV mean of a lesion, but of the whole patient's total tumor volume. Another concept I want to emphasize here is that on top of this traditionally used quantitative parameters, SUV mean, SUV max, SUV peak, etc. One important parameters on the PSMA PET is the location of the tumor, the metastasis, and how to incorporate the location of this tumor into this traditional quantitative parameters. So here are 3 patients. On the left, you can see a patient. This is a patient under evaluation for eligibility of lutetium PSMA. On the left, you can see a patient with bone-dominant metastasis. In the middle is a PSMA PET for a patient with lymph node-dominant metastasis. On the right is a patient with mostly visceral organ dominant metastasis, in this case, liver metastasis. Now we know that if you only look at like SUV mean or total tumor volume, some of this may be similar, but we know where the metastases are makes a huge difference. Some of the study had established that patient with liver metastasis will have a worse, potentially worse response to lutetium PSMA. So indeed, there's in one of the recent publications by Dr. Siefer from Germany, demonstrate that if you sort of incorporating tumor burden or quantitative tumor volume into location of the tumor, it was shown it can be associated with overall survival. For example, here M1A is the total tumor burden in lymph nodes. M1B is total tumor burden in bone metastasis. M1C is total tumor burden in visceral metastasis. So if you divided this into different quartiles, you can see total tumor volume for different regions of disease correlate very well with overall survival. So here I hope I sort of established that this total body biomarker, again, total body biomarkers are quite useful or essential for us to use as biomarkers, to prognostic biomarkers, at least for now, to evaluate potential treatments response. Next slide, please. Yeah. So, however, even though these biomarkers are, you can see it's important, essential, but currently they're not in routine clinical practice. There are several reasons for this, right? So first, again, this is a whole body quantitative parameters. It's not easy generate. So one of the studies by Dr. Gafida that they look at it using QPSMA. It's one of their quantitative program. It's a semi-automated a program to segment tumor volume to get this quantitative parameters. You can see each patient take about 13 minutes. So that's not realistic in our current really busy or getting busier clinical workflow. A second sort of obstacle to routine clinical adoption of these clinical parameters is that there are such a sort of still such a variability in terms of what radio tracer to be used. For example, Purify versus gallium PSMA or PSMA INT or 1007. You can imagine the SUV mean you get from these different tracers can be quite slightly different. So if you use a uniform cutoff of 10, can cause some problem for it to be adopted widely. A second point is that different centers uses different scanners, different reconstruction parameters, different sort of imaging protocols, how to draw ROIs. This can also sort of generate or cause differences, heterogeneity in the SUV readout. So there's a need for sort of have a system or a platform to generate this quantitative parameters that's relatively independent of this different sort of variable factors that could affect its wide adoption. Next slide, please. So a AI-based image quantification platform such as aPROMISE or Purify AI is one of this. I think it's one useful solution to help generate this whole body quantitative parameters or biomarkers. So it is based on PROMISE criteria, the prostate cancer molecular imaging standards evaluation criteria, and it's already adapted by ENM and EPSMA guidelines. So it can automate-based, it's AI-based sort of segmentation-based algorithm. It can generate this quantitative parameters relatively fast. A study from UCLA basically show that it can, on average, make that measurement in about 3 minutes compared to certain minutes we see from some of the semi-quantitative algorithm. On top of that, this program can generate a PSMA score, which is a quantitative score for tumor burden based on tumor uptake and volume, as well as the tumor location. For example, it's a local tumor, it's in the lymph node, or it's a bone metastasis, etc., visceral metastasis. So a little bit into detail about this APSMA score, hopefully I have time, is that, in the PROMISE criteria, there's a PSMA score. So when it's at blood pool uptake level, or slightly above blood pool, the PSMA score is 1, liver is 2, parotid gland is 3 of this reference organs. And this aPROMISE algorithm uses internal sort of reference organs to generate this a PSMA score based on that. So it can potentially take out some of this variabilities in terms of a different scan protocol, different centers, and also different tracers. So this is sort of very brief overview of what aPROMISE is, how that can be used or increase our possibility of routine clinical adoption of quantitative whole body biomarkers. Next slide, please. Yeah, so this is my last slide. I just want to briefly talk about some of the early preliminary study we did with this aPROMISE algorithm. We actually looked at a patient at biochemical recurrence when they had their PSMA PET. Almost all patients get a PSMA PET now, and we using the A-promise algorithm, we're able to generate quantitative parameters in terms of SUV max, whole body SUV mean, and total tumor volume, and also all these PSMA scores for bone metastasis, for lymph nodes, for local tumor, and all these parameters we show that it can be correlated with subsequent biochemical progression-free survival, because this is a statistically significantly associated with PFS with PSMA score from bone metastasis, from a nodal metastasis. Okay, this is pretty much all I have, but hopefully I give you an overview of what this biomarker is and what potentially we can do with this biomarkers using a AI based imaging analysis platform such as the A-promise. Thank you.
So it's a nice segue to the next session with Dr. Andre Gufita, where he is using quantitative and imaging biomarker for the first time as a response assessment, the RECIP criteria. So I will give you the baton now, Dr. Gufita, take us through your work.
Thank you. So in the next 15 minutes, we will discuss about PSMA PET as a biomarker for response assessment in prostate cancer. On the next slide, we will start by discussing the current standard of care, the state of art for response assessment in prostate cancer. And this is done according to the Prostate Cancer Working Group Criteria 3. And here I want to highlight that this criteria is validated and approved by the FDA to be used in phase 3 clinical trials to define radiographic progression that will ultimately lead to drug approval. The Prostate Cancer Working Group criteria consists of the CT and MRI to assess soft tissue disease according to the RECIST 1.1 criteria, and then the bone scan to assess the bone metastasis according to the so-called 2+2 rule, meaning on the follow-up scan, the patient requires to have 2 new lesions that have to be confirmed on a second follow-up scan with additional 2 new lesions. Now we will switch to PSMA PET on the next slide, where the first standardized criteria that was proposed for response assessment in prostate cancer using PSMA PET is RECIP, which stands for Response Evaluation Criteria in PSMA PET imaging. And can you go back? Yeah, on the right side, we see the definition. Progressive disease is defined as a 20% increase in total tumor volume and occurrence of at least 1 new lesions, while the partial response was defined as a decrease of at least 30% in total PSMA positive tumor volume without appearance of new lesions. On the left side, on the graphs, we see on the far left in green, on exemplified patients with partial response, we can see a dramatic decrease in total tumor volume and no new lesions. On the far right in red, we see a massive tumor progression in tumor volume and also multiple new lesions. In the middle in blue, we see a patient who does have a decrease in tumor volume. However, there was 1 new lesion, and because of the sign of progression, this patient was classified as having stable disease. And can you move forward? Thank you. And we see that the RECIP criteria defined as above was significantly associated with overall survival, meaning patients who had progressive disease had a significantly shorter overall survival compared to those with stable disease and also with partial responders. Now moving forward to the next slide. We compared the standard of care, the Prostate Cancer Working Group criteria, as we defined before, by CT, MRI, and bone scan. And what we did, we adapted this to the PSMA PET, meaning we replaced the bone scan with PSMA PET. However, we kept the definition of 2 new lesions in PSMA PET. And if we move forward, here we see the adapted version of the prostate cancer working group criteria. And we compare with RECIP to see if RECIP does have an added value to the working group, the adapted working group criteria. And moving forward, again, RECIP that is defined by changes in total tumor volume and occurrence of new lesions. And on the next slide, we see that both the prostate cancer working group, the adapted prostate cancer working group criteria and RECIP were significantly associated with overall survival, meaning both of them were prognostic biomarkers for response assessment in prostate cancer. However, on the next Kaplan-Meier plot, we see that, thank you. We see that about half of the patients did have progressive disease according to the adapted prostate cancer working group criteria, while only about 1/3 of patients, 32%, had progression according to RECIP. So there was a 20% discrepancy from the overall patient population. So we plotted all the patients here in this Kaplan-Meier plot that had progression by prostate cancer working group. Can you go next to see and also the next 2 buttons, if you can hit. Thank you. In red, we see patients who did have progression by RECIP, while in blue, those who did have progression only by adapted prostate cancer working group and not by RECIP. And we do see that patients who had progression by RECIP had a significantly worse outcome, shorter survival, compared to those who had progression by adaptive working group. So this data led us to conclude that the adapted prostate cancer working group criteria on PSMA PET may overcall progression and lead to premature treatment discontinuation. Now, moving forward to the next slide. So we have too many animations. And then probably one of the main issues that have been brought up today is that despite the quantification in PSMA PET shows high promise as a prognostic and predictive biomarker in prostate cancer, we do not have yet tools that are widely implemented in clinical practice. And as we've seen before, the original RECIP classification included total tumor burden quantification in PSMA PET. And we realized until this becomes reality in majority of radiology practices and hospitals across the world, we do have such tumor segmentation or quantification softwares, which cannot be used in practice or clinical trials. So in this study, we asked 5 radiologists or nuclear medicine physicians to visually or qualitatively assess changes in tumor volume, and then combine with new lesions and compute the visual RECIP and compare the agreement between visual RECIP with the quantitative RECIP that was done using tumor quantification software. I think you can move 3 or 4 buttons. Yes, thank you. So when we try to classify partial response versus stable disease versus progressive disease, we did not see great results. We saw only 45% agreement among readers. However, when we looked at classifying the patients just between progressive disease versus non-progression, we did see an 84% agreement among 5 readers. Now, moving forward on the right side, we evaluated the agreement between the visual and quantitative assessment in changes in tumor volume. Similarly, we found that when classifying progressive disease versus stable versus partial response, there was only an 81% agreement. However, for identifying only progression, we did see a 94% agreement between visual assessment by a radiologist, a nuclear medicine physician, and the tumor quantification software. So based on this data, we concluded, if we move forward, the next two buttons maybe, thank you, that in majority of cases, which is sufficient in clinical practice to just identify progression and maybe make a suggestion to switch the treatment, visual receipt may be sufficient and can be implemented in clinical practice and clinical trials. However, when classifying patients into progressive, disease stable, and partial responders, when we want to delineate between patients who do have a response and will likely do great compared to those with stable disease, there's where we need the quantitative tumor assessment. So if we move forward, yes, thank you. Now we can move to the next slide. But I think what actually gets me excited and where we do see a high potential for PSMA PET to drive the modern medicine is to completely automatically assess treatment response in prostate cancer using software, which is called the automated receipt. So in a study driven by UCLA, we did see that when the A-promise was employed to automatically quantify the total tumor volume in PSMA PET and also automatically identify new lesions and calculate the automated receipt or a receipt, they found very promising results. And if we move to the next slide, we will see that in the small retrospective study that included only 33 patients, in 100% of the cases, the fully automated receipt that was calculated using AI had an agreement with the quantitative receipt that employed both the software and the physicians. We can see that 4 patients had progression, 12 had a stable response, 8 were partial responders, and 9 of them had a complete response. And moving to the summary slide. Thank you. And we can hit the next 3 buttons. We can see that receipt can be calculated 3 ways. One, which is the easiest and probably what can be done today in every single practice, is the visual receipt that can be used only to identify progression. Then the quantitative receipt, where tumor quantification software is required, that also enables to subclassify between responders and patients that have a stable disease. And the last part, probably the most exciting again, is the automated receipt that has the potential to progress as a AI-based, fully automated response biomarker in prostate cancer. So I think this is what I had for today. And thank you. Feel free to use the rest of the educational platform. And if you have any questions, I'm happy to take them. Thank you.
I would like to, it's appropriate topic to move on the clinical context and the validation of PSMA PET biomarkers for its clinical use. So we'll hand off the baton now to Dr. Morris.
First, thank you so much for the invitation, and also I really enjoyed Andre and Hong's talks. So these are very informative. I'm just going to talk briefly about the biomarker development component of what's been alluded to here in both of the previous talks, and I'd like to address some of those issues head on. So next slide, please. So first of all, I think that it is really important, since we keep talking about biomarkers and the role of PSMA PET as a biomarker. None of us have really identified what a biomarker is yet, so perhaps we should do that. A biomarker, traditionally in the context of medicine, is a characteristic that can be measured and evaluated and quantitated as an indicator of a biologic process or pathogenic process, or a pharmacologic response to a therapeutic intervention. So the measurability, reproducibility, and quantitative aspects are key. And it's important to distinguish what a biomarker is from just what technology is. And PSMA PET is not intrinsically a biomarker. PSMA PET is an imaging modality and an imaging technology. From that PET, we have candidate biomarkers, so we can derive from the image some quantitative measure. And I think that both of the preceding talks gave some candidate biomarkers. But in order to turn a candidate biomarker into a qualified biomarker, you need to follow a process. Now, some of that process is for regulatory purposes, and those processes are outlined in various FDA and other regulatory documents. One of those was published in November of 2020. And the regulatory pathway is a difficult one because the bar is high. You need both a context of use that requires a biomarker. You need a good database of retrospective data and frequently prospective data that gives you a robust sense of association of what the measured entity is, how it correlates with a clinical outcome, and how what degree that correlation represents. But there are other contexts other than regulatory use for biomarkers. There's just clinical use for biomarkers. And that's a very different pathway. That may not be as robust. It may just be that there's an association, that's a strong association between what you're measuring and the performance of the patient or the performance of the intervention. And that may be very useful from a clinical standpoint and may not have a regulatory role. So, depending on what the use is, that the pathway towards that use is defined ultimately by what the application of the biomarker is. So next slide. Now, Dr. Gafita gave us a very nice introduction to Prostate Cancer Working Group 3, and I just want to use this for a slightly different purpose than he did. He was using it as a reference by which to compare the proposed response criteria that he's developed, but I'm going to use it as an illustration of process, and that is how we got to the point of having it as a recognized biomarker that supports drug approval. That process was the outlining of what the criteria would be through a document that then was termed Prostate Cancer Working Group 2, and then undergoing a series of prospectively designed clinical trials, looking at similar patients, undergoing similar therapy with similar trial designs, which ultimately yielded through those prospective studies enough association between the proposed outcome, that is rPFS, and the clinical event that was overall survival and clinical benefit, such that the FDA could then publish on their own, which is shown on the title above, whose lead author was Paul Klutz of the FDA, so that you could say that there's good confidence that the proposed endpoint has an association with clinical benefit to allow for recognition of it as a tool for supporting drug development in this context with this type of medicine and in a given clinical context that's recognized. So these were the 3 studies that prospectively furnished much of these data, although the article that from the FDA is based on the Cougar 302 study, showing a pretty reproducible and consistent prospectively established relationship between rPFS and OS. And just to remind everyone, 1 is a perfect association, -1 is a perfect inverse relationship, 0 is no relationship. So 0.7 is pretty good. It's pretty respectable. Not perfect, but good enough to have a relative benchmark for all future proposed biomarkers for clinical benefit when we think about future development of PSMA PET. Okay, next slide. So there has been some really nice work to date, some of which has already been touched upon in terms of building an evidentiary database to relate PSMA PET candidate biomarkers and clinical outcome. So Andre was just talking about his response criteria, but he also has a very nice publication looking retrospectively at patients treated with radioligand therapy that's PSMA directed. This employed thousands of patients, and this you're looking left. The nomogram that he developed, which is a multifactorial, multivariate analysis of the weighted value of each of these characteristics, and you'll see that that the SUV mean of the pretreatment PSMA PET has significant bearing on the prognosis of these patients and the outcome of these patients as they underwent treatment with PSMA-directed radioligand therapy. And then moving from his model into prospective data, the therapy study, which was a prospective study, a randomized phase 2 study, which compared PSMA-directed lutetium radiolabeled radioligand therapy with cabazitaxel in the metastatic CRPC patient population. You could see as well in this prospective data set a relationship between the SUV mean, which had a cutoff of 10, and outcome in these patients treated with PSMA directed therapy. The most mature of these is the vision study nomogram. So this is based on the prospective study that led to the registration of Pluvicto for metastatic CRPC. So this is the only nomogram that we have in terms of an actual phase 3 registration trial. And there too, you can see that the PSMA PET SUV mean carries a significant prognostic implication in terms of the patients who are undergoing treatment with PSMA-directed radioligand therapy, more so than any other characteristic. So the SUV mean is quite important. And as Dr. Gafita and Dr. Song outlined before, SUV mean is something that is not part of your routine report, is frequently requires software to generate, and so still has some hurdles to overcome in terms of the widespread application and use so that your average clinician can know what the SUV mean is. This is quite different, for example, than Prostate Cancer Working Group 3, which requires no software and the ability only to count to 2. So this is a little bit more challenging in terms of deploying in the real world as a candidate biomarker, because you need not only a PSMA PET, but you need some means of calculating the SUV mean of the patient. Next slide. Now, some of these were shown before in terms of the application of a candidate biomarker, such as the SUV PSMA mean. I'm just going to go into these in a little bit more detail. Dr. Song showed these data in his slide deck, but let's look at how PSMA PET has been used in terms of SUV mean from the VISION data set for both prognosticating or predictive use of either response or for overall survival. So first of all, as you can see in the top left, the SUV mean is really, this is the SUV mean divided of patients on the study shown by quartile. And with each quartile, the highest quartile representing the highest PSMA SUV mean, which was greater than 10. And then each quartile below that has a graded degree of association with prolonging radiographic progression-free survival, one of the 2 primary endpoints of the VISION study. So the higher the SUV mean, basically, the longer RPFS. That was not true in terms of overall survival. So if you look at overall survival in the panel in the lower left-hand corner, and this is just looking at the treated arm of the study. So these were patients who you're only looking at the SUV mean of the patients who received Pluvicto on this study. You can see that if you had an SUV mean of 9.9 or greater, you had a much better overall survival benefit than any other quartile. Basically, anything lower than an SUV mean of about 10 rendered you with a relatively identical and less beneficial overall survival benefit with treatment with Pluvicto. So there's a provocative concept there that for an on-study measure such as RPFS, which is measuring on-treatment effects, SUV mean has informative, it is essentially a continuous association with RPFS is somewhat different than an endpoint that not only measures the on-treatment but the post-protocol therapy survival, and in which case only the folks with the highest SUV mean by quartile seem to have the most prolonged or overall survival. That I frequently see, though, interpretation of that in terms in clinicians' hands as should I treat my patient with PSMA directed therapy if they don't have an SUV mean of 10 or higher? And that is, I think, the wrong question, because as you can see in the panel on the far right, when you look at the control arm, every PSMA SUV mean does better with Pluvicto than compared to the control arm of not receiving Pluvicto. So don't misinterpret what is an indicator of your best responder with whether they should receive treatment or not. This just identifies the group that's most for the best and most superior overall survival advantage. That doesn't mean that they don't benefit from getting treated with radioligand therapy. It means that they're just not in that group with the sweetest spot for a predictor of how long that they will live. It does suggest, though, that there may be other treatments that those patients who don't have an SUV mean of 10 or higher might do better with. And that's where the question is risen in terms of alternatives to radioligand therapy. Look, in the absence of anything else, better you receive radioligand therapy than not receiving radioligand therapy. But remember that chemotherapy was not part of VISION. And that's where we should make a transition from the VISION trial to the therapy study, which should be on the next slide, I believe. Next slide. Because the therapy study explored biomarkers in this clinical trial in which patients either received Pluvicto or chemotherapy. And to remind everyone about this trial, the primary endpoint was PSA decline. It was not a registration study. It was a randomized phase 2 with a PSA-based endpoint. The study was powered to look at a 20% decrease or 20% improvement in the PSA 50 response rate. And this directly compared as a secondary endpoint the overall survival between the two arms. The primary endpoint was the PSA response rate. So on the left-hand panel, you see the distribution of PSMA SUV means and response. And you can see that similar to VISION, those who had lower PSMA PET SUV means, they had a lower PSA response rate. And so this looks pretty good that PSMA SUV mean is a good predictor of response to radioligand therapy. And you saw much the same in terms of RPFS. And for those who recall the original RPFS curve, it looked like that RPFS benefit was after about 6 months of treatment, and PSA progression-free survival as well. But when you look at overall survival, and that's shown on the right-hand side of this, PSMA was prognostic, but not predictive in terms of the SUV mean for these two groups of patients. Now, if you recall, cabazitaxel and Pluvicto looked about the same in terms of overall survival in this randomized phase 2 study. And as you can see in the top line, when you look at PSMA SUV mean, if you have an SUV mean of greater than 10, you're going to do better than those who don't, whether you receive cabazitaxel or whether you receive Pluvicto. It doesn't matter, which would suggest a prognostic, but not necessarily a predictive role of PSMA SUV mean in terms of overall survival. The same was true in terms of tumor burden for these patients who were dually scanned with FDG. If you had more disease, you generally did more than if you had less disease. There shouldn't be anything surprising about that in terms of thinking about conceptually. Many measures of tumor volume will reflect that it's just bad to have more cancer than it is to have less cancer. So next slide. And that's going to be my concluding slide. So I think if I were to give just a summary, first of all, this is complicated stuff. It requires a lot of data for a specific context of use to answer a specific endpoint. And response may be very different than overall survival in terms of biomarker qualification and biomarker use. And also looking at different types of therapy may yield different results. So don't assume that one mechanism of action is the same as another mechanism of action when looking at PSMA. So we're going to have to do the work of gathering both retrospective and prospective data in order to understand the value of SUV mean. And remember that all of the data that I just showed were pre-treatment scans. The whole issue of how to interpret post-treatment scans or on-treatment scans will require a whole separate body of work so that we can understand response and so we can understand progression and what is the best candidate biomarker for the best mechanism of action and the best clinical context. Those may not be the same from one to another. And since we are talking about software, from one software package to another, and even one software version to another. Every time you change the version of the software and tweak it, you have to sort of start again in terms of biomarker qualification. That's a challenge. And then in terms of implementation, everybody needs to have the same software and be using that across the world in order to be using the same biomarker. So there are challenges here. And biomarker development isn't easy, but it's absolutely necessary. And I would say that it, in the end, is incredibly useful in terms of accelerating drug development and in terms of understanding how our patients are reacting to therapy, either favorably or unfavorably. And that's the end of my discussion.
I think we are out of time, so unfortunately, this is a really great discussion. I hate to cut this off. I hope there'll be a sequence 2 of this because it has been a pleasure hosting you and having these discussions with you. So thank you so much taking time from your busy schedule and having this very important discussion on qualification of biomarker. Field needs this and we need to do more of this. I appreciate your time. Thank you so much. Bye.
Thank you.
Thank you.
Thank you.
Thank you for joining today's webinar titled PSMA Imaging Biomarkers in the Management of Patients with Prostate Cancer. To learn more, please contact Polarify AI at Lantheus.com or visit us online at Lantheus.com or Exini.com. We look forward to having you join us for future webinars.